These are my disclosures. So endovascular aneurysm repair, transcatheter aortic valve implantation, and percutaneous mechanical circulatory support systems have become valuable alternatives to conventional surgery, and even preferred strategies for a wide array of clinical entities. Their adoption obviously is growing in everyday practice, and thus procedures require large bore closure. The large bore closure currently has been obviously between two devices that I'll speak about, but also there's a variety of new devices that are up and coming. Unfortunately, large bore closure is challenging. Vascular and bleeding complications have been shown to be as high as 20% in TAVR and 12 to 22% in EVAR. Obviously, these adverse events lead for patients to have prolonged hospitalizations, increasing the need for transfusions and increased short and long-term mortality. So as everyone's probably aware, our current practice is to use suture-based vascular closure to pre-close vessels prior to the procedure. The current innovation in this space is either to use one device, two devices, or a hybrid technique where you would use one device and then use a plug-based device, either with AngioSeal or MINX, to close. Two studies over the past 4 or 5 years have shown, however, that these current technologies continue to have high rates of complication. A study by Barbash called the CONTROL trial, which was a multi-center study, included 3,138 consecutive percutaneous transfemoral TAVI patients. They underwent closure with either ProStar or PerClose. Did show in the small subgroup that they propensity matched to have a fairly large major vascular complication or in-hospital mortality of 9.5% with ProStar and 5.1% with the ProGlide. And again, with the vascular complications, there's also the, the high number, almost 20% with the PerClose device. Another study was a post-hoc analysis from the Bravo 3 trial. The Bravo 3 trial was 802 patients randomized to receive either bivalve or unfractionated heparin during transfemoral TAVR between 2012 and 2015, which was conducted in 31 sites in Europe and in Canada. Of these, the 746 patients were treated with the PerClose ProGlide device, which was about 53% of them, and ProStar device, 47% of them. The devices were successfully deployed at 94% in the ProGlide group and 91% in the ProStar group. However, as you can see here also, the major and minor vascular complications are still 15% in the ProGlide. This shows that the ProGlide is probably safer than ProStar. However, I don't feel that these numbers are obviously appropriate, and obviously with the low-risk trial or patients coming about, could be a big issue going forward. So that leads us to a large unmet clinical need. Novel large bore closure should ideally, in the companies that are working in this space, are hoping to make it fully percutaneous, deployed post-procedure, easy to learn and use, safe and secure, and fully bioabsorbable. So the first device I'd like to talk about is the Telex Manta, which was recently FDA approved. It's an extravascular hemostatic bovine collagen pad, as seen on the right there, that has a polyester suture attached to the endoluminal bioresorbable toggle, seen in green, with a stainless steel suture lock. This device is placed post-procedure. It allows any size between 10 and 22 French based on the two device sizes. In order to place the device, it seems fairly straightforward. I've never used it in a patient, but only in pre-models. Before the index procedure, you locate the actual depth of the puncture. Then you exchange at the end of your sheath with the Manta sheath, insert the Manta position, and release the toggle, and finally deploy the collagen and seal, much like the AngioSeal device. Fortunately, last week, actually, exactly a week ago, this study was released in CIRC Cardiovascular Interventions, and it shows the safety and efficacy of the Manta percutaneous vascular closure device. So this was a prospective single-arm multi-center trial, 20 sites in North America. Patients underwent TAVR, PVAR, EVAR. About 80% of them were the TAVR patients. 341 patients were enrolled and 263 were in the primary analysis cohort. 84% of these patients received the larger size Manta, the 18 French versus the 14 French, and that has to do with the TAVR valve size and the post-valve placement. There was a 4.2% of VARC2 major vascular complications, which is obviously significantly lower than the ProGlide device and the ProStar device. And the mean time to hemostasis was 65 seconds, which was their primary outcome. Looking at the trial, the big thing was that 86% of the patients actually reached hemostasis under 1 minute. Another device that actually is hopefully coming to market in the future is called the InSeal Enclosure vascular closure device. It's a self-expandable nitinol frame seen in the bottom right that has a covered with a biodegradable membrane. Can be delivered via the procedural sheath post-procedure. The device closes anywhere between 12 French and 21 French holes, and it allows reaccess to the vessel through that membrane. So you can immediately do a procedure, the day or a couple days after. From a standpoint of patients, there have been 100 patients that this device has been put into, or a little bit more now, from Brazil, Germany, Israel, and Poland. They've shown no chronic complications at 1 year, and a clinical study that was performed showed 89% successful hemostasis, a less than 1 minute mean time to hemostasis, 0% major VAR complications bleeding, and 7.7% minor bleeding, and is currently CE mark approved. They're starting to work forward to try to attempt to get FDA approval. Next is the VividSure Medical PerQSeal, and this device is a patch-based, fully absorbable device. It's also delivered over the wire through the procedural sheath post-procedure. It seals up to 24 French punctures, fully absorbed in 6 months per the studies that they've done, but it requires a 7 millimeter vessel size to be placed. From a clinical standpoint, the Frontier clinical program has been evolving. The initial first-in-man was 11 closures. The most recent study that was reported was Frontier 3 in 2017 that looked at 62 patients with 70 closures because some of them had bilateral closures. They had a 97% technical success rate with no major vascular complications, 3 minor complications, and no late device-related complications. Frontier 4 started enrollment in Q4 2017, and I believe has just finished their enrollment. The data is still pending. They are CE mark approved currently. So in summary, these are the 5 devices that I talked about. Right now, ProGlide and Manta are the 2 big FDA-approved devices seen in the 2 left sides. PerQSeal and InSeal are going to be potentially out in the near future in the next year or 2. And ProStar, as we talked about, has a pretty high rate of complications, so I feel that it's going to be less and less used. So as someone new out of fellowship, I think the first thing that I learned and hopefully will continue to remember is good closure starts with good access. So I think pre-procedural CT scan planning is important, obviously looking at anatomical landmarks and using ultrasound guidance. What I think is the most important is being comfortable with one primary device and using it a lot just to make sure that you have the most experience with it, but obviously having a bailout option available. Thank you.